All right, everybody. So here is your Patho Week 7 review. There's my phone number if you need it. And here we go. So as always, I'm going to start here, read you the question, try to fill them out as best you can, and then unpause it, and then you can fill in what I have combined with whatever you were able to put. So first off, define the components of the circulatory system. So our vessels are going to be the tubing that our body carries blood throughout our entire body. So we've got three types. We've got arteries, we've got veins, and we've got capillaries. So arteries are going to be carrying your blood away from your heart. Veins are going to be carrying blood to your heart. Then capillaries are going to be the site of gas exchange, as well as nutrient exchange. And then just remember that veins carry our deoxygenated blood, arteries carry our oxygenated blood, except for whenever we get to the circulatory system. We have that one part where we have a pulmonary artery, which is where we have deoxygenated blood, but it's going to the lungs, but it's still going away from the heart. So even though it has deoxygenated blood, it's still going away. So that's why the pulmonary artery is named an artery. And then the pulmonary vein, which is coming from the lungs back to the heart, even though it's oxygenated blood because it's coming from the lungs, it's still going to the heart. So it's still named a vein. Okay, so next up, we got the fluid. So obviously the fluid, that's going to be the blood. And so this is responsible for, I'm just going to put carries because it carries all types of things. It carries oxygen, nutrients, hormones, electrolytes, waste products, all of that. So blood is kind of like the postal service of our body in that anytime something has to get somewhere, we use the blood. And then lastly, we got the pump. So the pump is obviously going to be the heart. So that's the muscular organ that whenever it contracts, it generates enough pressure to allow the blood to move. And so it ensures continuous forward flow throughout both the systemic and pulmonary circuits. And so if we come down here to talk about the systemic and pulmonary circuits, first off, we're going to start with the systemic side. And so in the systemic side, we're thinking about going from the body to the heart. So the first step is going to be our body. So like our tissues, for example. Then from our body, the blood will enter veins where they're deoxygenated because we just got done dropping blood off to the body or oxygen off to the body. So now we have to reload. So we go to the veins, and then the next step is that our venous system carries our blood all the way to the superior vena cava and the inferior vena cava. And so if you remember, that's our blood vessels that lead blood into the right atrium. So it doesn't really have it here, but if our right atrium is right here, our superior and inferior vena cava look like this, and they're returning blood to the right atrium from our body. Okay. Then once we have the superior vena cava and inferior vena cava, we're going through the heart. We end up in the lungs. So we went from right atrium to right ventricle. Now we've gone to the lungs, and now we're at the, I have to put that down, right atrium. And then from the right atrium, we hit the right ventricle. And then hopefully you remembered the valve in between the right atrium and the right ventricle. It's the tricuspid. And the other is the mitral or bicuspid. Okay, so now that we got that and we're in the right ventricle, now we've got the pulmonary circuit. So the pulmonary circuit, this is going to be involved in taking blood from the heart to the lungs, and then back to the heart again. So the first step we have from the right ventricle, we will pump into the pulmonary artery. So remember, this is the only artery that has in the body that has deoxygenated blood. And that's because even though it has deoxygenated blood, it's still moving away from the heart. And that's the definition of an artery. So it's moving away from the heart. Then from our pulmonary artery, we end up in the lungs. Okay, so now our deoxygenated blood is turning oxygenated. Then our next step is we have our pulmonary veins. So remember, these veins, even though they are veins, they're carrying oxygenated blood because they're still going to the heart. And so by definition, they're still veins. Then we have our, oops. Then we have our left atrium. Our left ventricle. And hopefully you remember that the valve here is the mitral or bicuspid valve. We got the left ventricle. And then lastly, we made it this far in the systemic circulation. So we're talking about blood going from the heart now to the rest of the body. So once the blood hits our left ventricle and our left ventricle contracts, we shoot our blood to the aorta, and that valve is the aortic valve. And then it goes to the rest of our body. And then we're going to identify any major vessels that are entering or exiting the heart. So we already talked about the superior and inferior vena cava. So these are putting deoxygenated blood in the right atrium. So the superior vena cava drains blood from our upper half of our body. Inferior vena cava drains blood from the lower half of our body. But all that blood ends up meeting back into the right atrium. Let's see. Okay, we talked about our pulmonary arteries and veins. So there's 4 of each. Pulmonary arteries are dealing with deoxygenated blood. Pulmonary veins are dealing with oxygenated blood. So just remember that's flipped here. And there's 4 total. And so just remember the pulmonary arteries are carrying deoxygenated blood away from your heart and to the lungs. And our pulmonary veins are carrying oxygenated blood to the heart. And then lastly, we've got the aorta. So this is the largest artery in the body. Largest artery in the body, and it's going to carry our blood from the left ventricle to our systemic circulation. Next up, identify the layers of the heart, differentiate the different heart valves, and then locate the mediastinum and describe the heart's position within the pericardial sac. Okay, so first up, we got the epicardium. So our epicardium is the outermost heart layer. Sometimes it's also known the visceral layer. So here we go. Visceral layer of serous pericardium, that's your epicardium, that's the outside. And so this is going to be responsible for things like protecting the heart. So you want to have that tough outer layer, but also it provides lubrication because remember, if we have our heart pumping all the time, we don't want to have a lot of friction. And then as well as offering additional structural support. So that's this outside part right here. Next up, we have our myocardium. So this is our thick muscular layer. And this is the layer that's going to be responsible for doing all of our contractions. So it contains a high density of cardiac muscle cells, also called cardiac myocytes, and these are responsible for the pumping action. So myocardium is this giant area of muscle right here. All right, then we have our endocardium, and this is the innermost layer. So our endocardium is this little tiny area right here, all the way at the very, like pretty much against the heart. And so what this does is it kind of smooths the lining of the different chambers and the valves, but it also reduces turbulence. And it's also continuous with the vascular epithelium. So we have blood vessels that are running along in here. Okay, and then we got the pericardial layer. So that's going to be the sac that's actually surrounding the heart. So what we have right here first is our fibrous pericardium, right here along the outside. And so that's this tough, kind of dense outer layer. And what it does is it anchors the heart to the diaphragm. And it also kind of prevents over distension of the heart. Okay, then we've got our parietal layer. So that's this next little area right here. And so that lines the inside of the fibrous pericardium, but it produces serous fluid. And remember, that reduces friction. Then we have our visceral layer, like we talked about, and then we have the pericardial cavity. And so that's actually the space between the visceral and the parietal layer of our pericardium. It doesn't say it right here. Oh yeah, actually it does right here. Pericardial cavity. So this area right here is going to have that fluid, that serous fluid, and that helps to reduce friction. All right. So next up we got here, differentiate the heart valves and their function. So we got 4 different heart valves. We have the AV valves. That stands for atrioventricular because they're in between the atria and the ventricle. So the atrioventricular valves, and we have 2 of them. In order, it goes the tricuspid. It's called tricuspid because we've got 3 leaflets. And then the other one is the mitral or bicuspid valve. It's called that because we have 2 leaflets. All right, then we've got our semilunar valves. And the 2 here is the aortic valve and the pulmonic valve. So our aortic right here, that's to go from our left ventricle to our aorta. And then our pulmonic valve is to go from our right ventricle to our lungs. Okay. And so as far as functions for these, so the function of the the AV valves is to open during ventricular filling, also called ventricular diastole, because we want to have the valve open. We want to have this valve open whenever we're trying to get blood to the right ventricle or the left ventricle. If that was closed, we wouldn't be able to do that. And then just remember, these are supported by these little tiny muscles called our papillary muscles and our chordae tendineae. So our papillary muscles are these little muscles right here that control the valve. And our chordae tendineae are those little hair-like structures that actually pull the valve open. So if you haven't seen those pictures, maybe go back and look at those real quick, and they'll make sense for you. Okay, and then for this one, for our semilunar valves, these are going to want to be open during ventricular systole. And you want these open because if the blood is here, you want these valves to be able to be open so that we can pump blood to the aorta and the pulmonic arteries. And then just side note, there's no chordae tendineae on these. None of those little hair-like structures. Okay, and then lastly, locate the mediastinum and describe the heart's position within the pericardial sac. So the mediastinum, it's the central component of the thoracic cavity. And it's located obviously between your lungs. So there's your lungs. And it contains all the things like the heart, the great vessels, even like the trachea, the esophagus, the thymus, all of those are in the mediastinum. And so the heart specifically, though, it sits right in this middle mediastinum right here. We have the different areas right here. And the heart is enclosed within my pericardial sac, like we were talking about. Just remember that the top area, that's called the base. And the bottom area, that's called the apex of the heart. And then lastly, about 2/3 of the heart, roughly, is going to be and slightly to the left of the midline. All right. So describe the conduction pathway of the heart, explain the role of the SA node, and then identify the EKG waves. All right, so I have the order right here, but I'm going to come over here and talk you guys through it like with the picture. So the first step is our SA node right here. And so our SA node is our pacemaker. This is what sets the pace of your heart. And it's going to set it about 60 to 100 beats per minute. So yeah, just remember our SA node, it's located in the right atrium. And this is what's going to be generating and setting the sinus rhythm for our heart. Next one we have is the AV node. So we're going to notice this one is kind of right along the floor of the right atrium. And something important here, let me find it. Here we go. Something important here is that there is a delay in our conduction here. And the reason that it's delayed is because this allows our ventricles to fill. So it allows our ventricles to fill up. And this is our backup pacemaker. And so it keeps us from about 40 to 60 beats per minute. So if you have an MI and you knock out your SA node, you might still be fine, but your heart rate is going to be slowed down big time because now you're operating off the AV node. Okay, next step is the bundle of His. So that's this area right here. It's not labeled, but it's the only electrical connection that you're going to be able to find between the atria and the ventricles. And it carries the impulse to the interventricular septum. And so let me put bundle of His. Because the next step is we have our left and right bundle branches right here. And so these are going to conduct impulse down the interventricular septum, and it directs impulses towards the apex. Because remember, the apex is at the bottom of our heart. And then last, we've got these Purkinje fibers. And so these are actually spread throughout the ventricular myocardium. So within the ventricular heart muscle. And they're responsible for producing rapid and coordinated ventricular contractions because you want these ventricles to contract at the same exact time. You don't want one to go and then one to go. It's got to be at the exact same time. Okay, explain the role of the SA node as the pacemaker. So we talked about this. It keeps your heart rate at 60 to 100 beats per minute. This is what's going to actually be initiating the heartbeat. And then, like I said, if your SA node fails, your AV node has to take over, and it'll be slower. It'll be about 40 to 60, but at least it will be taking over. And again, this is found in the right atrium. All right, and lastly, identify the EKG waves and what they represent. So we've got the P wave first. P wave is going to be atrial depolarization. So this is where the electrical activation starts, and it's right before the atria contract. And then the atria would contract right around here. Then we've got our QRS, okay, and this is for ventricular depolarization. Okay, and that's why the signal is so much bigger, is because we have all that ventricle muscle, that ventricular myocardium, and we're having to send an electric impulse through that, and it takes a lot. So that's why the wave is so much bigger than the atrial one. And then finally, we have the T wave. This is for our ventricular repolarization. So this is where the ventricles reset electrically for the next beat. And so the reason we don't see an atrial, because we have atrial depolarization, ventricular depolarization, we have ventricular repolarization, but we don't ever have atrial repolarization. And the thing is, we actually do have it, but this QRS wave is so big that it kind of blurs out that wave. So that's why we don't ever see it. So understand the ionic movements in the cardiac action potential, and then relate the action potential phases to either contraction or relaxation. Okay, so as you can see here, phase 0 is where we have very, very rapid depolarization. And so the membrane potential here is going to actually shoot upwards. And this is the actual electrical trigger that initiates that ventricular contraction. So we need this part right here to kick off the entire thing. So we have very, very rapid sodium influx. That's what we mean when we say depolarization. And then we have phase 1. So this is going to be our early repolarization stage. And that's why we have potassium efflux or out. And so because we have that brief outward efflux of potassium, we have this slight little downward notch. And then just remember that the sodium channels also close here because we don't want to keep depolarizing. Okay, phase 2 right here, this very flat phase, that's what we call the plateau phase. And so what's important here is we've got calcium influx, but we still have that calcium or the potassium efflux. And so this phase here, this stage here is critical for contraction. So whenever we have the calcium that's entering the cell, it triggers calcium induced something called calcium induced calcium release. From the sarcoplasmic reticulum. And so what that is just the release of calcium causes more calcium to be released. So if you guys remember, that is a positive feedback mechanism. And so what this does is it produces sustained ventricular contraction, and it allows for all of our blood to be ejected how it should be. And then phase 3, we have the repolarization phase. And so in this phase right here, we have predominantly potassium efflux. It's going to be dominating. Calcium channels are going to close, and then the membrane potential starts to get closer to our resting. And then phase 4 is where we hit our resting membrane potential. And so we have down here our sodium potassium ATPase, or our sodium potassium pump, that's going to fix our electrolytes back to our resting level. That way we can depolarize again and start another action potential. And at this stage, so right about here, the cell is ready for the next depolarization. Okay. So autonomic control of the heart. So explain the sympathetic effects, the parasympathetic effects, and then the baroreceptor function. Okay, so just real quick, you'll remember we have, if we're breaking down our nervous system, we have our central nervous system and our peripheral nervous system. So central nervous system is going to be things like our brain, spinal cord. I like to think of the peripheral nervous system as literally everything else, but we have two areas. We have our autonomic and we have our somatic. And so autonomic can get further broken down into our sympathetic nervous system and our parasympathetic nervous system. So sympathetic nervous system, we have fight or flight. Parasympathetic nervous system, we have rest and digest. So for the sympathetic nervous system, you need to think things like our body is releasing epinephrine and norepinephrine. And so because of this, we have increased heart rate, increased contractility. So this is just how fat or how hard your heart is beating. And then just remember that whenever we release this epinephrine and epinephrine, what causes the increased heart rate is the binding of epinephrine to beta 1 adrenergic receptors in the SA node. And the AV node in the myocardium, but I just mean the SA node is where all of it's starting. And so this is, we talked about this is our fight or flight. So pretty much everything that would happen whenever you're running from a bear, that's what would happen whenever we have sympathetic effects. And so if we switch that around a little bit, we're talking about the parasympathetic nervous system, so our rest and digest. This thing does things like decreases our heart rate via our vagus nerve or cranial nerve 10. And so what this does is our vagus nerve releases acetylcholine. So this acetylcholine will bind to our muscarinic receptors in the SA node and the AV node. And so when it binds to those muscarinic receptors, we have slower SA node firing, slower AV node conduction, reduced cardiac output, all things that would happen if you say that you finally outran the bear and now you need to relax and calm down. And the baroreceptor function, so the baroreceptors are in our aorta and our carotid arteries, and they're used to detect our blood pressure. So there's one in the aortic arch and one at the carotid sinus, which is in the internal carotids. So when our blood pressure rises, we have kind of two options here. So when our blood pressure rises, we have the medulla that decreases its sympathetic nervous system output. So think about it. Our blood pressure is too high. So our sympathetic nervous system is like, okay, we need to tone this down because there's normally vasoconstriction whenever we have our sympathetic nervous system firing. But if our BP is already high enough, we don't need further vasoconstriction. And so if we're decreasing our sympathetic nervous system output, it's going to cause increased vasodilation plus a decreased heart rate. And our body doing that will bring our blood pressure back to normal. Now, if it's low, what's going to happen is our baroreceptors are going to start firing. That's going to increase our sympathetic nervous system output from the adrenal medulla. And that's going to cause increased vasoconstriction. Plus, we'll have an increased heart rate. So both of these, this is directly acting on the blood pressure. The increased heart rate is adding blood to our vessels, which is increasing our blood pressure that way. And if you remember the baroreceptor function in your carotid, you can actually trick your body. If your heart rate is really, really high, you can push your finger on one of your carotid arteries, and it will trick your brain into thinking that your blood pressure is actually higher, and that will lower your heart rate. So, okay. Now, factors that are affecting heart rate. So identify physiological factors that increase your heart rate. So there's a few things that just think about what increasing your heart rate does. It increases your blood flow, which increases oxygen to the area, increases nutrients to the area. It also takes away waste from the area. So all of those are kind of results of increasing your heart rate. And so in times of like a fever, exercise, or stress, you need oxygen. So obviously your heart rate's going to kick up because it's going to help your blood get dispersed to your body faster. Your thyroid hormones, so remember that's your T3 and your T4. So those are your metabolism hormones. So obviously if those increase and your metabolism's going higher, then obviously your heart rate's going to increase to keep up with that. Pain always causes increased heart rate, so always causes tachycardia. Then smoking, and then pregnancy. And then explain how temperature and hormones can. Oh, and then real quick, smoking does this through nicotine. So nicotine causes sympathetic nervous system stimulation. And then pregnancy, obviously, just because you have increased blood volume, because you're carrying around another human. And then you have increased blood volume plus increased metabolic demand. So all of those reasons are why you'd have to have increased heart rate. So how temperature actually does it in hormones. So if you have heat speeds up SA node firing. So that's why it will actually increase. And then another reason that we have is increased metabolic demand. So if you have an increased metabolic demand, that means you're going to have an increased oxygen requirement. And so that's why your heart is going to kick up because like, oh, we need more blood to the area. And then as far as how hormones affect us, so I told you T3 and T4, these are your big metabolism hormones. So if your metabolism goes up, like we said here, so does your O2 requirements. And so your basal metabolic rate, that's just like the bare minimum amount of calories that you need to stay functioning. That increases, but you also have increased oxygen consumption. Your heart will become more sensitized to catecholamines. And so whenever these are released, so like during times of stress or exercise or pain, they'll bind to this beta 1 adrenergic receptor, which increases your SA node firing, AV node conduction, all that fun stuff. All right, coronary circulation. Okay, so identify the coronary artery origins. So first up, we have our left and right coronary arteries. And so these actually arise from our aorta. So here's our aorta right here. And we're the biggest artery in the body. But if you look right here, we have these little out pouches right here, right here. So we've got our right coronary artery and our left coronary artery. It's coming right off of our aorta. And remember, we have oxygenated blood flowing here. And so what's cool about the aorta is that we have our ventricular contraction, right? And the blood flows up this way. But whenever we have diastole or it relaxes, what happens is that some of the blood that got pushed up here kind of drains down. And that's how our heart gets supplied with oxygen, is that passive flow. And so, yeah, so these are part of the systemic circulation. And so now if we're going to differentiate between the LAD, the circumflex, and then the right coronary artery branches. So the LAD, sorry, I know it's not very clear, but it's right here. So the LAD stands for left anterior descending. It's also known as the widowmaker because a lot of the time you could have a clot right here. And because that clot finds its way there to the left anterior descending artery, what the problem is, it supplies the left ventricle and the interventricular septum. And so if you have a clot and you're not getting blood to your left ventricle, that means you're not going to be pumping blood effectively to the rest of your body. And so that's why it's called Widowmaker, because it's this critical perfusion territory that if you lose your left ventricle, you're in trouble. Then we've got the left circumflex. So that one's right here. Kind of goes around the heart, comes around to the back. And so that supplies the left atrium, some of the left ventricle, and maybe the SA or AV node, kind of just depending on the dominance. Then we have our right coronary artery. So we talked about that. Comes down right there. But the branches are the right marginal artery. So we've got this one down here. And that supplies the right ventricle. So remember our right ventricle right there. Then we have our PDA, or our posterior interventricular artery. So that supplies the inferior wall of the ventricles and then the posterior interventricular septum. And it's actually, you can't really see it all that well, but it's right here and it's on the back of the heart. They're just drawing it. They drew it in like a faded out color so you can see that it's running along the back. And then lastly, why is collateral circulation limited in the heart? So the problem is coronary arteries, they have very few natural, just kind of collateral vessels. And so the myocardium, which is the heart muscle, it has a high oxygen demand, obviously, because it's pumping all day, every day, and it has little tolerance for ischemia. And so whenever we think of these coronary artery branches, they're more like end arteries. So if one of them gets obstructed, there's minimum, like you can't really change the blood flow all that much. Like this one right here, you can't really change the blood flow all that much because there's only one artery right here. And so this collateral development, and that's where you'll kind of make alternative blood flow areas. It occurs slowly, so typically you're going to think about this in a chronic disease, but it's not fast enough in acute occlusion. So, like if you have a clot that comes right here, your heart is not just going to be like, oh, that's okay, we can just form blood vessels this way. No, this happens over a long period of time. And so the heart has almost no backup routes. And so because whenever you have this sudden blockage, it leads to very sudden ischemia. And that's where you start to have issues. Okay, so we're going to look at the cardiac cycle. So we got systole and diastole. So let's start with systole first. So when you think of systole, you're going to think of contraction of that myocardium or ejection. We're ejecting all that blood. So just know that the ventricles are going to contract. The AV valves will close. And then the opposite semilunar valves are going to be open. Right? Because these close, the AV valves close because we don't want backflow. So when the ventricles contract, when our ventricles contract this way, we don't want the blood going back this way. So that's why the AV valves are closed right here, so that all the blood can go to the next point. Okay, then we've got diastole. So I just want you to think, when you hear diastole, think of relaxation. So that's when your ventricles are going to relax, opposite of here. So we've got AV valves are open. Our semilunar valves are going to be closed. And then just remember, this is also whenever our coronary arteries fill. All right, now the full cardiac cycle. So from the atrial filling, all that. So first step, we have blood returning from the IVC or the SVC, so our superior or inferior vena cava, and it ends up in the right atrium. So this is the atrial filling is when we have blood coming from the IVC and the SVC to the right atrium. Now, once they are filled up, we have blood going from the right atrium to the right ventricle. Okay, so that's this area right here. And then right here we have our tricuspid valve. So the atria fill, we have atrial systole that sends blood through the tricuspid valve to our ventricles. Now our ventricles are filling and filling. And then we have right here, we have our pulmonic valve because we have ventricular systole, and that sends blood to the pulmonary arteries. And then explain isovolumetric contraction and relaxation. So isovolumetric contraction, this specifically occurs right after your AV valve closes. And so what this means is that the ventricles are contracting, but it's this short time in the cycle where all the valves are closed. And so the volume stays the same because whenever we're contracting, we're not shooting blood out, but we're also not taking blood in because all the valves are closed. But your pressure continues to rise, and then it'll continue to rise until it kind of busts that semilunar valve open, and then all the blood will leave. But it's called isovolumetric because iso means same, and volumetric, so same volume. And it's the same volume because all four valves are closed. So our volume of blood is not changing, even though our pressure is, because our ventricles are still squeezing together. And then relaxation is going to be the exact opposite. So this is going to be right after the semilunar valves close. And so again, the volume stays the same, but the pressure is going to be falling. But all four valves are closed, and that's why the isovolumetric, that's why it's called that. All right, let's go over the heart sound. All right, so they pretty much have them all here for you. So I'm not going to draw too much, but the lub sound, that's the AV valve closure sound. This is your S1 sound. So when the atrioventricular valves close, so just a reminder, we're talking about our tricuspid and our bicuspid or mitral valve. And it happens at the very start of systole whenever the ventricles are just contracting. And when the ventricles contract, that's what you're hearing is your valve slamming shut. Then we have dub, so that's the semilunar valve closure. So that's our S2 sound. And we're thinking our aortic or our pulmonic valve. And this is going to actually happen at the very start of diastole, or so whenever our heart's relaxing. And whenever the ventricles relax, that causes the semilunar valves to close. So murmurs are turbulent flow from incompetent valves. So remember, we've got two different kinds of flow. We've got laminar flow. We've got turbulent flow. So laminar flow is just whenever blood is flowing just like this, nice and smooth. You can't really hear anything. Turbulent flow is when we have blood flow, but then it hits something. And this area right here, that's what you're hearing. And so murmurs are going to be abnormal heart sounds. It's caused by this turbulent blood flow right here. It's most commonly due to like incompetent or leaky valves that don't close completely. Heart murmurs are actually pretty common, but it can also occur whenever you have stenosis. So whenever your valves are hardened and narrowed. And then lastly, explain what a pulse deficit is. So the difference between apical and radial pulses. So a pulse deficit is anytime you have a difference between the apical pulse, which is what you hear, versus the radial pulse, which is what you feel, right about at the wrist. And so this occurs whenever your ventricular contractions are not strong enough to produce a palpable pulse in the wrist. And so a lot of the times you'll see this in things like AFib. You might also see it in PVC. So if you remember, those are preventricular contractions. Then you also see it. You also might see it on weak ventricular output. So if your ventricles just are not working all that well, you'll see this pulse deficit. Okay. Define cardiac function. All right, so we have this formula here. So if you're like me and you hate math, this gave you a heart attack a little bit the first time you saw it, but hopefully you realize that it's actually not that bad. So CO is our cardiac output. HR, obviously that's going to be our heart rate. And this is our stroke volume. So cardiac output, that's just going to be the amount of blood that our ventricles put out in 1 minute. And so that's measured by stroke volume, which is okay. How much blood do we have going out? And heart rate is how often do we have this blood going out? And so if you combine those two together, you get cardiac output. And so just in general, cardiac output will always increase if we have an increase in heart rate or stroke volume. So explain preload. So preload is the amount of blood that is returning to our heart. So preload is the amount of volume, blood volume returning to our heart. And so this determines our ventricular stretch. And the more stretch that we have, so if we have a stronger stretch due to increased preload, so increased preload leads to increased stretch. This leads to increased contractility. This is also known as inotropy. And so this little lull right here, this is known as the Frank-Starling mechanism. So if we have increased preload, so increased blood returning to our heart, that's going to mean, okay, our heart's going to be like, oh, I have more blood, which means I need to pump harder. Increased contractility. Okay, now explain afterload. So afterload is the resistance the ventricle must overcome to eject blood. So we have our heart right here. We've got our aorta. So our ventricle wants to pump blood this way, obviously, right, to our aorta. The problem is because we have blood sitting right here already, plus we have things like peripheral vasoconstriction, that causes a force down this way. And so all this is saying is that our ventricle has to pump our blood with such a force that it overcomes this so that it can get to the rest of our body. So an increase in afterload means that your ventricles are going to have to work harder every single time, and so that will actually decrease your stroke volume. And so how does the sympathetic nervous system, blood volume, and resistance all affect cardiac output? Well, our sympathetic nervous system, if you remember, that's our epi and norepinephrine. That's going to cause increased heart rate, increased inotropy. Remember, that means increased contractility, and it's going to lead to increased cardiac output. Now, if we have increased blood volume, well, actually, you know what, we'll just do both. So if we have increased blood volume is going to lead us to increased venous return. So remember, increased venous return is increased preload. And because we have increased preload, that's going to increase our stroke volume because every contraction that we have is going to have more blood. And so because of that, we have an increased cardiac output. Now, if we reverse this, so say that we have low blood volume. It could be something like dehydration, could be hemorrhage. That's going to decrease the preload that we have, so decrease the amount of blood returning to the heart. So because of that, we're going to have a decreased cardiac output. Okay. Talk about the different parts of blood pressure. So systolic versus diastolic pressure. So systolic blood pressure is going to be the pressure in your arteries when the vessels, oops, not vessels, when the ventricles contract. So ventricles contract, your blood pressure is felt. Typically, this is going to be the peak pressure during your ventricular ejection. And then if you're reading a blood pressure reading, say normal is 120 over 80, this is systolic. This is diastolic. So systolic pressure is exerted when blood is ejected from the ventricles. And so it's always going to be higher because it's always that initial push. Then we have our diastolic pressure. So this is the blood pressure when our ventricles are relaxing. And so this is basically a baseline pressure maintained by our arteries. And so this is going to be our bottom number, like we talked about, our diastolic. And it's sustained pressure when our ventricles are relaxed. And that's why it's so much lower, right? Because it's during diastole. During systole, we have a higher pressure because our ventricles are contracting. So that's why it's higher. So explain how cardiac output, blood volume, and peripheral resistance determine blood pressure. So cardiac output, our blood pressure is always going to rise when cardiac output rises. Okay, and so that could be okay. So blood pressure rises when cardiac output rises, and so that could be from an increase in heart rate or a increase in stroke volume. And then obviously the opposite is true. So when BP falls, cardiac output falls. And then for blood volume, so we just kind of do two here. So when we have increased blood volume, again, actually, I'm not going to do it again because I have it right up here. Forgot I did that. So go right up here. This is answered by this one. And then peripheral resistance. And so that's going to be determined by your arteriolar diameter. So if all of your vessels look like this, but then some of them look a little bit smaller, this is going to, if we're trying to push blood through it this way, obviously it's going to be harder. So we're going to have an increased pressure here. So your heart feels that. Describe the sympathetic nervous system effects. I feel like we've pretty much beat a dead horse with this one. So just remember we have increase in epi or norepinephrine. Those are catecholamines. So with that, we have increased heart rate, increased blood pressure due to vasoconstriction. Okay, and then lastly, we have the hormonal regulators. So ADH, aldosterone, and RAS. So ADH, remember this is our antidiuretic hormone, and it causes increased water reabsorption in the kidneys. So if we have increased water reabsorption, we have increased blood volume, which will increase our blood pressure. Aldosterone works sort of the same. I won't even say that. But anyway, aldosterone is a hormone that causes increased sodium reabsorption. And because we have sodium reabsorption, we also have water reabsorption. And so because both of those increase our blood volume, we have an increase in blood pressure. Then lastly, we have RAS. So basically what happens here is that if we have a strong decrease in blood pressure, specifically felt by our kidneys, this causes the RAS pathway. And the RAS pathway not only ends in aldosterone secretion, but it also ends in angiotensin II production, and that is a potent vasoconstrictor. Okay. This one I don't really have too much for you. This was more just I wanted to put down a few of the diagnostic tests and what we use them for. So obviously we use an EKG to diagnose dysrhythmias, different MIs, pericarditis even. Auscultation. So obviously this is going to be best done with a stethoscope. And just remember your mnemonic, apartment M2245. Somebody also said earlier this week, you can remember this as all physicians take money. But really what's important you remember here is we have aortic, pulmonic, tricuspid, and mitral. And so at each of these landmarks, that's where you're going to be able to hear each of these valves. So at the right second intercostal space, you'll be able to hear your aortic valve. Then at the left second intercostal space, you can hear the pulmonic valve. At the left fourth intercostal space, you can hear your tricuspid valve. And lastly, at our left fifth intercostal space, we can hear our mitral valve. Echocardiogram, obviously, to look at specific valve motion and kind of look at our cardiac output. Stress tests, they test for different functional capacities. That's where they put somebody on a treadmill, usually. Cardiac catheterization. So cardiac catheterization can be done for a few different reasons. It is an invasive procedure, and what they do is they put a catheter through your heart vessels. It can do a lot of things. So it can measure pressure, but it can also visualize your coronary arteries. So it can see if there's any plaque buildup. Doppler studies for peripheral flow. So it evaluates that peripheral flow, but it also looks for any vascular obstruction. And then obviously your blood tests for your electrolytes. So remember, electrolytes can pose an arrhythmia risk, specifically with potassium. Then we have our lipids, so atherosclerosis risk. And then our ABGs tell us stuff like oxygenation, acid base status, things like that. Okay. Again, I just put this in here as more of a summary slide. There's not too much to talk about. General cardiac guidelines is that, so say for hypertension, first thing you want to do is look at things that you can change easily without medication. So limit your fat intake, decrease your salt intake. Exercise, obviously, that's a good thing. So it increases your HDL. And so that's the high density lipoproteins. That's the kind that you want, because that brings, well, never mind, I won't get into it. But yeah, just know that you want to keep your HDL high and you want to keep your LDL low. Smoking cessation, obviously, that's always a big thing, especially whenever we talked about nicotine. Nicotine is a very strong vasoconstrictor, and because of that, that causes increase in blood pressure. And then there's a bunch of different drug classes, which we'll talk about. Right, angina pectoris. So what even is angina pectoris? So angina pectoris is chest pain that is caused by an oxygen deficit to the myocardium. So for any number of reasons, your heart is pumping either too fast or too hard, and your body can't keep up. So your heart is just beating, 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 and then it starts to be able to not become oxygenized the same way. And so basically, it occurs whenever coronary blood flow cannot meet this demand. So there's some kind of a blockage. Just remember though that angina means ischemia. It does not mean infarction. This is just signs that your heart is pumping and it's not getting the blood flow that it needs. So now we have the three different types of angina. So we have classic. You might also hear this as exertional. So this is triggered by things like stress, exercise, any kind of increased workload. It's a very, very, very predictable pattern, and it's caused whenever you have that increase in myocardial oxygen demand. And this is going to be relieved by either rest or a good dose of nitroglycerin. Now, your variant angina, this is caused by coronary artery vasospasm. So remember, vasospasm is where we have an artery right here, and then all of a sudden we have just sharp vasoconstriction. Not necessarily related to exertion, so this could just also happen. Then lastly, we have the unstable angina. So what's most important about this, it's where you have prolonged chest pain, but the most important thing is that it's at rest. And so this usually indicates impending myocardial infarction, so not good. And this is actually considered to be part of what's called acute coronary syndrome. Okay, and then explain nitroglycerin's mechanism. So nitroglycerin, not only is it a strong coronary vasodilator, right? So if we have some kind of an obstruction that's blocking it, vasodilation would be good because it's giving our blood more room to flow, but it's also a systemic vasodilator. So what this is doing is that's ultimately decreasing our preload. And if we're decreasing our preload, our heart's not going to have to beat as fast. And so that's decreasing our myocardium oxygen demand. And because we're decreasing the oxygen demand, that increases our perfusion because we're not beating quite as hard or as much. So just kind of in a summary, nitroglycerin reduces the work the heart has to do. And so if you have less pressure, there's less demand. And then the emergency steps for treating angina. So what you're going to want to do firstly is to stop any and all activity. So if our heart already can't keep up with our workload, we're not going to want to be doing more activity. 2 is sit the patient up. So what we're trying to do is we're trying to decrease our preload. So if you lay somebody back, all that blood is going to be coming from their veins to their heart, increasing their preload, which is going to make their heart have to work harder. And that's what we're trying to avoid. 3, that's when we get our nitroglycerin. Make sure you deliver it sublingually. That's how it works fastest. Or you're going to want to check their pulse, make sure everything's okay. And then 5, give oxygen if needed. And then just know that if somebody has known angina, like it's happened before, you can give them a second dose of nitro. But if there is no history of angina, you're going to want to call EMS immediately because they might be having an MI. So myocardial infarction. So a myocardial infarction means the total obstruction of a coronary artery. And so when we have that total coronary obstruction, that leads to ischemia. So if, say, for example, we obstructed our left coronary artery, and so we have our LAD, or our left anterior descending, aka our widowmaker. Say that becomes clogged, then we have ischemia of the left ventricle. Then we start to have necrosis of the left ventricle. So we have death of that myocardial tissue. Because we have that, our heart's not going to be able to pump as well, and so our body's not going to be getting blood, and that's why it's called a widowmaker heart attack. So some of the causes, so atherosclerosis, so that's where we have our blood vessel right here, but then you've got fat on both sides, and it makes it really hard for all that blood to get through. Thrombus, so that's where we have our blood vessel right here, and all of a sudden you have usually like a blood clot that's blocking blood flow this way. Or vasospasm. So we talked about that. That's where we have just the random vasoconstriction. Okay, so differentiate the two types of myocardial infarction. So, or two different types. These are not the only two types, but STEMI versus non-STEMI. So that stands for ST elevated. This one stands for non-ST elevated. So in your STEMI heart attacks, usually going to be due to total occlusion of an artery. So your STEMIs are going to be your pretty bad ones. Typically, you'll have more severe damage. The STEMI heart attack. And it's usually a complete or full thickness infarction. And what you'll actually see on an EKG is that ST segment elevation. Versus our non-ST elevated, so this is usually going to be like a partial thickness or infarction, but there is no ST elevation at all. It's usually due to some kind of a partial occlusion. And then your troponins are still going to be elevated here. So watch for that. And troponin, remember, that's the main cardiac enzyme that you're going to be looking for during a myocardial infarction. So basically your cardiac muscles die and they release this protein into the blood. And so the warning signs of a myocardial infarction, so chest pressure, or any kind of heaviness or burning, shortness of breath, nausea, weakness or fatigue, radiating pain. The pain, interestingly enough, is usually substernal. We got a little bit of chest. It's usually described as a crushing pain, but you can also, from the radiating pain, you can get pain in your left arm. Sometimes people have it in their left jaw, or even their left, like in their neck area. Any of those can be signs of myocardial infarction. Okay. So MI treatment. Okay, yeah, so the diagnostic markers, we pretty much talked about that in the last little bit here. So these are the ones you're going to want to look for, but mostly troponin, that's your big one. The complications of an MI, obviously sudden death. Yeah, I don't really have anything. Just sudden death, cardiogenic shock, congestive heart failure, thromboembolism. All of those are complications of what happens after an MI. And then as far as the treatment goes, you're going to want to reduce your cardiac demand, whatever that kind of includes. So if that tells somebody to rest, maybe limit their activity, you're just trying to reduce the workload on the myocardium. That's the main goal. Oxygen therapy. So you're going to want to increase your oxygen because it gives oxygen to the ischemic tissue. And analgesics. So sometimes morphine. Morphine's a common one. But basically, what it does is they reduce pain and the anxiety. So they just bring down your sympathetic nervous system. Anticoagulants. So what that's going to do is that's going to prevent further thrombus formation. So think of things like maybe the first one that comes to my mind is heparin. And then thrombolytic. So the first one that comes to my mind is TPA. This is your clot buster. All right, cardiac arrhythmia or cardiac dysrhythmias, I should say. All right, so cardiac dysrhythmias is whenever you have your normal sinus rhythm and something goes wrong. So a few of these it could be caused by electrolyte abnormalities. So the biggest one, again, potassium, doesn't matter whether it's hyper or hypokalemia. Both of them can cause dysrhythmias. Fevers can, because remember, heat messes with your SA node, hypoxia, stress, but any kind of sympathetic nervous system activation. Drugs, so for example, we can think of digoxin, that's a big one. So remember, digoxin treats congestive heart failure. But then we have things like stimulants. So those are also known to cause dysrhythmias sometimes. Um, and so sinus bradycardia, tachycardia, and sick sinus syndrome. So sinus bradycardia is just whenever we're beating at our heart's beating at 60 beats per minute. And that doesn't even necessarily mean that it's dangerous. Like athletes will sometimes have bradycardia where their resting heart rate, like my aunt, is very, very, very athletic, and her heart rate is like high 30s to low 40s. Her resting heart rate. Tachycardia is going to be anything that's considered over 100 up to about 160 beats per minute. So your heart's just beating really fast. This is usually going to be due to like pain, fever, stress, things like that. And so sick sinus syndrome, this one's actually dangerous. This is where we actually have alternating brady and tachycardia. And so this is usually going to require a pacemaker because our heart is not able to control the rate by itself. So this is an SA node dysfunction. So atrial flutter slash fibrillation. So atrial flutter, this is going to be when our atrial rate goes from like 160 to 350 beats per minute. That is incredibly fast. And so because of that is our AV node is actually blocking a lot of the impulses. And so what that does is that decreases our ventricular rate. And so if we have in general, if we have decreased filling time, so if our chambers have less time to fill with blood, that's going to cause decreased cardiac output. So because we have that decreased cardiac output, we have blood stasis. And the problem with blood stasis or blood staying still is that blood starts to clot. And so AFib, this is where we have atrial contraction, but the rate is 350 or more beats per minute, which is absolutely insane. There's no coordinated muscle contraction. It's literally just it's just fibrillating. And so what happens is the blood pools in the area, thrombus formation, and then you can have an embolic stroke. All right, so recognize ventricular tachycardia, fibrillation, and PVCs. So look these up on an EKG. Oh wait, whoops. I was looking at the wrong one. So describe your heart blocks. So we've got a first degree heart block. Remember, this is where you have a prolonged PR interval. So maybe I should have put the EKGs on here, but go ahead and maybe pull these up and you'll be able to see what I'm talking about. So all impulses are conducted, usually going to be asymptomatic, but you do have the prolonged PR interval. Second one we have is we have some impulses are dropped. Some of our impulses will be dropped. And so if we have these missed ventricular beats, that's going to eventually lead to decreased cardiac output. And then lastly, third degree, this is as bad as it gets. This is complete blockage. So we have no impulses between the atria and the ventricles. They're beating completely independently. And so because of that, we have a strong, strong decrease in our cardiac output. And so typically that's going to lead to syncope. So they're going to pass out, and then they can usually have a pacemaker put in to control for that. Okay, and then also be able to recognize these on an EKG, but also be able to explain them. So ventricular tachycardia, we know this is where the ventricle is beating way too fast. So our ventricular rate is way too fast. Because of that, we have decreased diastolic filling. We have decreased filling because all they want to do is beat, 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 beat. And so because of that, it can lead to ventricular failure. And if we have that, we're not pumping any blood anywhere. Ventricular fibrillation, so it's where they're quivering. There's no coordinated contraction how there should be. And so because of that, we have no cardiac output. And so that gives us cardiac standstill. And so we need immediate defibrillation. So a lot of people think, oh, I need to feel if they have a pulse. If they have no pulse, we need to shock their heart with the defibrillator. But you don't want to shock somebody's heart when it's standing still or like when it's not beating. That's not the point. You want to shock somebody if they're in something like VFib, where it shocks their heart back into regular rhythm. So it won't, defibrillator will not start your heart again. It will just reset your heart rate. Then we've got these PVCs. So remember, these are premature ventricular contractions. And this is where you get extra beats. So extra ectopic beats from the ventricular muscle. And so that can trigger ventricular failure if it's frequent enough or it gets paired right. All right, and then identify the treatment. So antiarrhythmic. So obviously you're going to be thinking things like maybe beta blockers. We have the calcium channel blockers. The other one we had was digoxin. So what we do is we use these to slow the heart rate, improve conduction, and then you want to suppress those ectopic occurrences. All right, so we're gonna go over a few of the high yield conduction disorders. Again, this is pretty much everything that we talked about down here. Oh, I didn't realize I put, okay. So I didn't realize I put these here. So if you want to know what these look like, they're down here. So a right bundle block versus a left bundle block. And then this is the main problem. So in AFib, the main problem is a thrombus risk. And then in VFib, the main problem is cardiac standstill. But I would still go on and look at what they look like. All right, high yield drug actions table. So nitroglycerin, again, this is a very potent vasodilator. And what this is doing is it's decreasing workload due to it decreasing our blood pressure and decreasing our preload. Metoprolol, that's a beta blocker. It's going to be working to decrease our heart rate. Nifedipine, this is a calcium channel blocker. And how this is going to work is by vasodilation. So it's taking some of that work off your heart. Digoxin, what digoxin does is it actually increases our contractility. So it increases how hard our heart is going to be pumping. And it does this by decreasing the conduction in the AV node. Enalapril, so anytime you see pril, this is an ACE inhibitor. So remember, ACE converts angiotensin 1 to angiotensin 2. Furosemide, I would just know that this is a strong diuretic. Decreases blood pressure, decreases workload on our heart. Simvastatin, so that anytime you see statin, that's a cholesterol medication, so decreases lipoproteins. Warfarin is an anticoagulant. And then ASA is our antiplatelet. And that's why they tell you to sometimes take a baby aspirin. They think you're having a heart attack. All right, and last up here, coronary artery disease. So understand oxygen imbalance and recognize the progression. So with oxygen imbalance, it begins when myocardial oxygen supply is lower than what we can demand. So the O2 supply, for any reason, is lower than what we are able to give. Whoops. Yeah. So our demand is much higher than our supply. So that could be for a number of different things. So think maybe atherosclerosis, leading to fat buildup in your arteries. Could be the vasospasm. So remember, that's our extreme vasoconstriction. Could be maybe tachycardia could cause it. Different anemias could cause it. And so because we have this oxygen imbalance, that leads to ischemia, which is where a part of our heart is not getting enough oxygen. So because of that, we have a pain signal known as angina. So chest pain, and that chest pain can be indicative that we are about to be led into an MI, or myocardial infarction. The good thing is that ischemia is, at this stage, still reversible. And so basically what happens is that your cardiac muscle cells, your myocytes, they switch to anaerobic respiration because they're not getting oxygen, right? So they have to switch to anaerobic. And when they switch to anaerobic metabolism, they have an increase in lactic acid buildup, and that's the pain that you're feeling. But there is no cell death yet. There's sometimes you could show ST depression, maybe T wave inversion here. But just know that we have lactic acid buildup. And then angina, that's the clinical angina right here. Chest pain, it's the clinical symptom of ischemia. It's chest pain from inadequate blood flow. Remember our three kinds: stable, variant, and unstable. And then we finally have the MI, which, yeah. And so the progression, we go from stable angina. So this is where we have our predictable pattern. Typically going to be triggered by exertion. Remember, we can relieve this by rest, and if not rest, at least nitro. Unstable angina is going to occur at rest, but it's caused by maybe a plaque rupture, or maybe like a partial thrombus that finds its way there. And there's usually a high risk of imminent AI. So a high risk of myocardial infarction. And then lastly, an infarction, so that's where we have total occlusion. Total occlusion of an artery. So like myocardial necrosis, for example. The bad thing is that this leads to irreversible damage to the muscle tissue. And so this requires emergent treatment.